Thank you all. Welcome to the June 2019 ACIP meeting. I'm calling the meeting to order, and now I'll turn it over to Dr. Cohn.
Good morning, everyone, and welcome to the June 2019 ACIP meeting. Next slide. The proceedings of this meeting are accessible to people not in attendance via the World Wide Web. Welcome to those who cannot attend the ACIP meeting in person. There are CDC staff at the entrance to the rooms to help guide you, and there's also a desk in the lobby to assist members of the public with questions. Handouts of slides to be presented have been distributed to the ACIP members and are available for members of the public on the table outside of this auditorium. Additionally, slides are available through a share file link for liaison and ex officio members. Slides presented at this meeting will be posted on the ACIP website approximately 3 to 4 weeks after the meeting. The live webcast videos will be posted in approximately 4 weeks, and meeting minutes are posted on the ACIP website, generally within 120 days of the meeting, but minutes from the February 2019 meeting will be posted shortly after this meeting. To ensure the health and safety of all individuals attending this meeting, a few safety regulations are going to be reviewed. In the event of an emergency resulting in an evacuation, the procedures are as follows. For the back of the room, exit out the rear doors and across the bridge the way out you came in, exiting the building the way you came in. For those of you seated in the front of the room, please exit through this door up here and then turn right down the stairs. Locate the blue building marker sign labeled outside, Conference and Meeting Space, GCC, second floor, and group together. I also want to remind attendees to please do not leave bags unattended. Next slide. This is a picture of the emergency exit procedures, which we are very highly unlikely to need, but for your information. Next slide. And you are likely to need food and drinks during this very long meeting. At this meeting, coffee and breakfast items are served outside in the lobby. There will be Chick-fil-A served during lunch hour. These services will be available both meeting days. If you do leave the building during lunch, please anticipate lines as you get back in and get back to the meeting on time, because we will definitely start on time. Next slide. The next ACIP meeting will be convened at CDC on Wednesday and Thursday, October 23rd and 24th. Registration for all meeting attendees is required and will be open on the ACIP website on the date the Federal Register notice is published. I want to remind people that we are now limiting registration so that all members who have registered for the meeting can participate in this room. So registration will close when capacity is full. Registration is not required to view the meeting on the World Wide Web. Next slide. So our liaison member substitutions for this meeting, Jeff Chushen actually is our new IDSA representative along with Carol Baker. I apologize for saying he's a substitute, but the two of them will be alternating meetings. Clem Lewin will be representing Pharma at this meeting, and Marcus Pleskia will be representing ASTO at this meeting. Next slide. I'm going to pass it off to Dr. Romero, who's going to talk about our departing members as this is their last meeting.
So for those of us that are members of the ACIP, this is a bittersweet meeting for us because we say goodbye to individuals that we've worked with for the last 4 years. And so with that, after I introduce each of them, they can have a minute or two to say a couple of comments. So Dr. Izanolowe is from Nevada. He's been with us since 2015. He's been on the General Best Practices Work Group and the Hepatitis Work Group. We're going to miss him greatly. I'm going to miss him. He was actually my mentee the first year he was here. So, Eche, any words?
No, it's been a really an honor for me. It's someone who didn't actually grow up in this environment to see how policies are made in a way where it's allowed their expertise in science to trump every other political thing. So for me, sitting down here for the past 4 years has been a great learning. Thank you.
Thank you. Next slide, please. Dr. Kelly Moore from Vanderbilt University. She is the rival for the Art Reingold Award for most chairmanships in the most chairs in the ACIP. So you can all see there that she's been the chair of 4 work groups: the Combined Vaccines Work Group, the Hepatitis Work Group, the Mumps Work Group, and the Zoster Work Group. And she's also been member of the Meningococcal Work Group. She's brought with her a tremendous experience in public health and has brought the perspective of public health to the committee. So thank you very much. The floor is yours.
Oh my, you may regret that. No. Yeah, it is. I came to my first ACIP meeting in 2005 as a member of the audience, and I haven't missed a meeting since. And so making it through being a liaison representing the Association of Immunization Managers for 5 years, and then these last 4 years as a voting member has been the best privilege of my professional life, and it has been such a delight to get to know each of you, and the quality of the work we've accomplished here is something I'm always going to be proud of. Thanks.
Thank you. Next slide, please. Dr. David Stevens, our homegrown member. He actually doesn't have to travel very far, doesn't get the perks of the mileage that we all get. He's from the University of Emory University. He's been the chair of the Anthrax Work Group. He started and entered that work group, which is no easy task, as those of you who have been here for a while. He's had a very quiet demeanor, but a very strong influence on the group, bringing his thoughtful and measured perspective to topics that we've discussed. Dr. Stevens.
So I prepared this 30-minute speech, but I want to thank the committee members for the last 4 years. It's been wonderful to be a part of this group. It's a fine set of individuals, if you will, and I appreciate the opportunity to have been a part of the group. I also want to thank CDC and the ACIP leadership. This has been a great group to work with, and I look forward to continuing to promote vaccine policy. Thank you.
Thank you. Next slide. Dr. Chip Walter, he's professor of pediatrics from Duke University School of Medicine. He's been the chair of 2 work groups, the influenza work group and the flavivirus work group, and a member of the dengue work group. He's been the chair of one of the most complicated work groups, which is the pneumococcal work group. Influenza, excuse me. Influenza, forgive me. I'm getting ahead of myself. Of the influenza, which has had to analyze a lot of data and had to make decisions based on very little data sometimes. So again, thank you for your service here. Go ahead.
Thanks. I did write down a few things. So it's really been an honor and I think a highlight of my professional career to have served as a member of this committee for the past 4 years. I think this committee does really fantastic work evaluating all the available information and trying to make the recommendations and the best recommendations for use of vaccines for controlling vaccine preventable diseases. Through the past 4 years, I've had the opportunity to work with incredible folks from the CDC. Without their information and resources, and they really go the extra mile to assist this committee with its deliberations. Furthermore, the opportunity to work with all the members in the committee, I think it's really fantastic that it changes every year. You get to work alongside a number of really talented and diverse members. So I really want to just express my gratitude for having had this once-in-a-lifetime experience. Thanks.
Thank you. We're going to call the members up for a presentation of a small gift to remember us with, if you don't have enough to remember us with. But
And I do just want to make one comment. These 4 members in particular started their ACIP experience at the same time that I started mine in this role. And so I really feel like I kind of grew up with the 4 of you, and I appreciate all y'all's leadership and mentorship of me over the last 4 years. And so we have for each of you a different Dr. Seuss poster from the CDC days talking about vaccines. Chip, y'all can all come up at the same time. We'll just. So these are Dr. Seuss posters that promote vaccines. I think many of you have seen these in the past. We have one for each of you. And we'll sign them later. And can we get a picture, Jess? Can we get a picture? Let's get them.
Get around you.
Yeah, sorry.
We'll do this the right way.
Right. Not quite yet. Yes. Okay. So I just wanted to remind everybody that in the ACIP charter, that committee deliberations on the use of vaccines to control disease in the U.S. shall include considerations of disease epidemiology and burden of disease, vaccine efficacy and effectiveness, vaccine safety, the quality of evidence reviewed, economic analyses, and implementation issues. I just wanted to make sure that everybody saw this as we started our deliberations today, as I think all of these different aspects of decision making will come into play. Next slide. Keep going. Next slide. To improve the clarity of ACIP's recommendations, recommendations based on clinical decision making between the patient and the provider will be referred to starting at this meeting as shared clinical decision making recommendations. This differs slightly from previous phrasing of individual clinical decision making, but the intent is the same. Shared clinical decision making is a better understood concept among clinicians and better describes that this is not a decision made by an individual, but made between two people for an individual. Next slide. The ACIP is, at its heart, a public body, and engagement with the public and transparency in our processes is vital to the committee's work. As part of ACIP's commitment to continuous improvement, we have strengthened our public comment process to accommodate increased public interest in ACIP's work. For this meeting, we'll be holding public comment periods prior to the votes for each day. The oral public comment period will occur at 1:30 each day of the meeting, and to create a fairer and more efficient process for requesting to make an oral comment, people interested in making an oral comment submitted a request online and were selected by lottery in advance of the meeting. Next slide. For written public comments, we're using a docket on regulations.gov where any member of the public can submit a written comment. This process allows for people to submit longer comments and the ability to include attachments. Comments are visible to the public in a longer window for comment submission. So you can continue to submit comments through this meeting up to 48 hours following the end of the meeting, and all comments submitted by 72 hours prior to the meeting will be made available to the ACIP members prior to the meeting. Next slide. As noted in the ACIP's Policies and Procedures manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on safety data monitoring boards may present to the committee on matters related to those vaccines, but they're prohibited from participating in the committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in the discussions with the provision that he or she abstains from all votes for any vaccine related to that company. At the beginning of the meeting, when we conduct roll call, we'll review our conflicts of interest. And at this meeting, we'll also review our conflicts of interest prior to each voting session. Next slide. Detailed instructions for submission of names of potential candidates to serve as ACIP members is available on the ACIP website now. Right now, we have that applications for ACIP membership are due no later than July 1st for the 4-year period, but we're actually extending that to August 1st, and we really encourage people to apply. We are looking for several new members. This is to begin in July of 2020. Next slide. So I want to make 2 more comments before I tell you guys to turn off your phones. The first is that Dr. Narayan is also retiring from the U.S. Public Health Service and from his position at HRSA, and this will be his last meeting in attendance. He's been attending in the role as the HRSA liaison for the last 5 years, and we've all really appreciated your input and participation with ACIP. And then the second comment I'm going to make today is that we have a very packed agenda for today, and we're going to try to stay on time as much as possible. But we will potentially be going over time during certain sessions, but the breaks will be very, we will definitely start back when we say we're going to start back from the breaks. So please, when we take a 10-minute break, please be back in your seats in 10 minutes. So I'm going to pass it on to Dr. Romero now for a roll call.
Very good. So now we'll take roll, and please, will the current voting members please indicate if you're present and disclose any conflicts of interest, and I will start. So Jose Romero, no conflict of interest, and I will go to my right.
Grace Lee, no conflicts.
Veronica McNally, no conflicts.
Kevin Holt, no conflicts.
Peter Szilagyi, no conflicts.
Kip Talbot, no conflicts.
Robert Atmar, no conflicts. Hank Bernstein, no conflicts.
Ezanolua, no conflict.
David Stevens, no conflicts.
Kelly Moore, no conflicts.
Paul Hunter, no conflicts.
Chip Walter, no conflicts.
Sharon Fry, no conflicts.
Thank you. Very good. So starting with Dr. Melinda Wharton. Oh, sorry. Nancy, that's the name. Introductions, and then will the ex officio members and liaison members introduce themselves, and please include the name of the agency or organization you are representing.
Good morning, everybody. Nancy Messonnier, CDC, and I have next to me 2 esteemed division directors who are our subject matter experts for the next meeting. That's why they're up here. Thank you.
Good morning. My name is Ann Aiken. I'm representing the new Office of Infectious Disease Policy, which used to be the National Vaccine Program Office.
John Weigel from the National Institute of Allergy and Infectious Disease, NIH.
Narayan Nair with the Health Resource Service Administration.
Doran Fink with the U.S. Food and Drug Administration.
Tom Weiser with Indian Health Service.
Jane Kim, Department of Veterans Affairs.
Mary Beth Hans from the Centers for Medicare and Medicaid Services.
Amy Middleman from the Society for Adolescent Health and Medicine.
Sean O'Leary from the Pediatric Infectious Diseases Society.
Clem Lewin from Pharma.
Patsy Stinchfield, National Association of Pediatric Nurse Practitioners.
Carolyn Quash, National Advisory Committee of Immunization, Canada.
Matt Zahn of the National Association of County and City Health Officials.
Bill Schaffner, National Foundation for Infectious Diseases.
Jeff Duchin for the Infectious Disease Society of America.
Christine Hahn, Council of State and Territorial Epidemiologists.
Phyllis Arthur from Bio.
Marcus Plesha, Association of State and Territorial Health Officials.
Christine Finley, Association of Immunization Managers.
Steve Foster, American Pharmacists Association.
Stan Grog, American Osteopathic Association.
Chad Riddle, American Nurses Association.
Sandra Freihofer, American Medical Association.
Rebecca Coyle, American Immunization Registry Association.
Ken Schmader, American Geriatric Society.
Linda Eckert, American College of Obstetrics and Gynecology.
Carol Hayes, American College of Nurse Midwives.
Susan Even, American College Health Association.
Marie-Michelle Léger, American Academy of Physician Assistants.
David Kimberlin, American Academy of Pediatrics Red Book.
Bonnie Maldonado, American Academy of Pediatrics Committee on Infectious Diseases.
Pamela Rockwell, American Academy of Family Physicians.
Thank you and welcome all. So we'll move on to our first topic, which will be human papillomaviruses. Dr. Peter Szilagyi will give the introduction.
Thank you very much. So, as Dr. Romero said, I'm Peter Szilagyi, and I'm chair of the HPV vaccine work group. So I'd like to introduce today's session. As a reminder, these are the current recommendations for HPV vaccination in the United States. Routine vaccination at age 11 to 12 years, though vaccination can be started at age 9 years. And of particular note for today's session is that catch-up vaccination for females is through age 26 years, and for males through age 21, although males age 22 to 26 may be vaccinated. And there are no recommendations for vaccinations of adults older than 26 years. Thank you. 2 HPV vaccination policy issues are being brought to ACIP for a vote today. First, related to harmonization of catch-up vaccination, should catch-up HPV vaccination be recommended for primary prevention of HPV infection and HPV-related disease for all persons through age 26 years? And second, related to vaccination of adults older than 26 years, should catch-up HPV vaccination be recommended for primary prevention of HPV infection and HPV-related disease for all persons aged 27 through 45 years? So why are we considering these 2 issues? First, for harmonization. The work group had discussions back in 2017 and 2018 related to simplification of the vaccination schedule, and background for this policy issue will be provided in the next talk. Second, for vaccination of adults older than 26 years, the manufacturer filed an application in April 2018 to expand the age indication for 9-valent HPV vaccine from age 9 to 26 years to age 9 to 45 years, and this was approved by FDA in October 2018. So HPV vaccine sessions at 3 separate ACIP meetings have focused on these expanded age indications. And the next 2 slides, this one and the next one, will show the topics that we have discussed. In June 2018, we presented an overview and presentation on the history of the application for the expanded age licensure, a review of HPV epidemiology, the natural history and burden of disease. And the manufacturer presented clinical trial data submitted in the SBLA for the 9-valent HPV vaccine in adults aged 27 to 45 years. So that was June of 2018. In October of 2018, we had a number of presentations, and this included a review of the regulatory basis for the licensure for the expanded age range, several aspects of the U.S. HPV vaccination program, including vaccination coverage and the current evidence of the impact on infection and disease. There was a review of HPV epidemiology, sexual behavior and post-licensure effectiveness, and also a brief update on the global HPV vaccination and vaccine supply, highlighting the current demand and supply imbalance. GRADE was presented for efficacy, immunogenicity, and safety of the vaccine for adults older than age 26 years. And there was a summary of the health economic analyses. And in addition, initial policy considerations that were being discussed by the work group were presented. And at that time, the work group introduced the option of individual clinical decision-making. Now, in February 2019, we presented an overview of the natural history, a presentation on the impact and cost effectiveness of mid-adult HPV vaccination using the HPV Advise model, and an overview of health economic results from 5 different models that were being considered for this policy question. We presented information on patient values and acceptability, and findings from program and vaccine provider surveys about the expanded age indication for HPV vaccination. Updated considerations and policy options based on continued workgroup discussions and deliberations were also presented. Okay, so the ACIP vaccine workgroup has been working very hard with many meetings since the February 2019 ACIP meeting. First, we continue to review updated results from models of HPV vaccine impact and health economics. Second, the work group heard an industry presentation on the global HPV vaccine supply and current shortage. Third, we had a preliminary review of data on 2 topics, HPV vaccine in HIV-infected adults, as well as data on HPV vaccination post-treatment for anogenital disease. And both topics require additional data and discussion, so our work group will be discussing these in the future. Fourth, 9-valent HPV vaccine immunogenicity and safety trial data that were recently completed were presented to the work group a month ago, and ACIP will hear these data today. The work group reviewed the evidence to recommendation documents and finally continued to discuss recommendation options. So regarding the work group considerations for vaccination of adults older than 28 years, at the February 2019 meeting, the options presented for the work group for consideration included clinical decision-making or not making a recommendation. And very importantly, not one member of the work group was in favor of routine universal recommendation. So this was not discussed as an option. After the February 2019 ACIP meeting, there were discussion options being proposed, and these were shared clinical decision-making, using the new term, and do not recommend the intervention. And again, a third option was not being discussed because not one workgroup member recommended universal vaccination. As you'll hear later this morning, the workgroup reached consensus on the first question, harmonization of catch-up vaccination. Should catch-up vaccination be recommended for primary prevention of HPV infection and HPV-related disease for all persons through 26 years of age? Regarding the second question, vaccination of adults older than 26 years, two options are being considered: a majority opinion and a minority opinion from the work group. So these will be discussed today. So for today's session, Lori Markowitz will discuss the background. Dr. Alan Luxembourg from Merck will discuss 9-valent immunogenicity and safety trial in women 27 to 45 years of age. Harold Chesson from CDC will discuss an overview of the economic models for HPV vaccination for mid-adults. Alyssa Miedis from CDC will discuss the evidence to recommendations. And Lori Markowitz will come back and discuss the work group considerations. And I would really like to thank the HPV vaccine work group. We've worked very hard over the past year. Jose Romero and Kevin Alt as ACIP voting members, the ex officio members, liaison representatives, CDC contributors, and of course, Lori Markowitz, who's the CDC lead for this work group. So Lori Markowitz will present the next topic.
Okay, so in this presentation, I will provide some background, further background for the session this morning. And specifically, I'll provide background on the two policy issues being considered. As you heard, harmonization of catch-up and vaccination of adults older than age 26. And I will also include an update on the global HPV vaccine landscape. So as just some very basic background, this table shows vaccines licensed in the United States, the manufacturer and the licensure ages. Before October 2018, 3 vaccines were licensed. The bivalent vaccine licensed for use in females 9 through 25 years. The quadrivalent and the 9-valent were licensed for use in females and males 9 through 26. And although 3 vaccines are licensed since the end of 2016, only 9-valent vaccine has been distributed in the United States, and bivalent and quadrivalent vaccine continue to be available in other countries. And then in October 2018, 9-valent vaccine was licensed through age 45 years. And I want to emphasize that although 9-valent vaccine was only recently licensed through this age in the United States, all 3 vaccines have been licensed through age 45 or older in other countries. However, no country has a public health HPV vaccination program targeting adults older than age 26. Again, these are our current recommendations, which include routine and catch-up for females is recommended through age 26 and for males through age 21, as well as certain populations through age 26. A little bit of history on the recommendations. Vaccination for females was recommended in 2006. At that time, the vaccine was only licensed for use in females. Routine vaccination of males was recommended in 2011. And vaccination was first recommended as a 3-dose schedule, and a 2-dose schedule was recommended in 2016 for those starting the series before age 15 years. Quadrivalent was the first vaccine licensed and recommended in 2006, bivalent in 2009, and 9-valent was recommended in 2015. Almost all vaccine used in the United States was quadrivalent vaccine through 2015, and then, as I mentioned, after 2016, only 9-valent vaccine was distributed in the United States. Data from the National Immunization Survey teen show coverage increasing gradually in females. Shown here is at least 1-dose coverage in orange, and in red, 3-dose coverage or up-to-date coverage in 2016 and 17. And up-to-date is the measure that has been used since the 2-dose recommendation for persons starting the vaccination series before age 15. In 2017, at least 1-dose coverage in females was 69%, and up-to-date was 53%. And in the blue lines are coverage for males, which has increased more rapidly than for females since the 2011 recommendation. At least 1-dose coverage was 63% in 2017, almost similar to females, and up-to-date coverage was 44%. And understanding coverage is important as it impacts some aspects and inputs to our models. Now, in spite of coverage being lower than target goals, dramatic decreases in vaccine type prevalence and other endpoints have been observed in the United States. These were detected within 4 years of the program introduction, and further reductions have been observed in subsequent years, and some of these data will be reviewed in the evidence to recommendations presentation. Now, how did we get to different catch-up age for the current recommendations for males and females? Well, routine vaccination of males was considered by ACIP after quadrivalent was licensed for use in males, and data were available on efficacy for prevention of anal precancers. ACIP considered policy for males using GRADE, including health economic analyses, and these health economic models show that inclusion of males in the vaccination program was less cost-effective than female vaccination, and that vaccination became less cost-effective with increasing age. Vaccination of males was recommended at 11 or 12 as for females, but catch-up through age 21, and ACIP considered the health economic modeling data when recommending the age for catch-up vaccination. There has been increasing interest from partners and stakeholders in harmonizing the upper age for catch-up recommendations across genders for simplification of the vaccination schedule. In 2007-18, before CDC awareness of the manufacturer application to FDA for the 9-valent vaccine expanded age range, the ACIP HPV vaccines work group was considering harmonization of catch-up and through age 26 years. The work group delayed harmonization of after consideration of harmonization after FDA agreed to an expedited review for the expanded age in April 2018. At that time, it was unclear what the health economic analyses would show for adult vaccination, and we wanted to avoid multiple recommendation changes in 1 year. The health economic analyses have been much more challenging than anticipated, as will be reviewed by Dr. Chesson later in the session. However, the work group is now ready to move forward on both harmonization and adult vaccination decisions. Regarding the work group's deliberations on the second policy question being considered today, vaccination for adults older than age 26, the work group also considered this policy decision harmonized across genders. Over the past year, as you heard in the introduction to this session, the work group reviewed a wide range of data. And I want to highlight that as presented at past ACIP meetings, there is uncertainty about some aspects of HPV natural history. I also want to highlight that the work group considered results of 5 health economic models. 3 models were used initially, and 2 additional models were included to inform policy after October 2018. CDC's desire to include additional models was due to the disparate results obtained across models initially considered. And the modelers and the ACIP CDC economic team has been working very hard over the last year to understand the modeling results, and you will hear more about this later today. 4 of the 5 models predict high cost per quality for expanding the catch-up age range. The presentations today will summarize data presented to ACIP over the last year, and much of this will be summarized in the evidence to recommendations presentation. The only new data today will be some of the health economic modeling data and new data from a 9-valent immunogenicity and safety trial. These are the first data on 9-valent vaccine in 27 to 45-year-olds. Now, regarding those new data, I want to remind everyone that licensure of 9-valent vaccine for use through age 45 years was based on results of a randomized controlled trial of quadrivalent vaccine that included women 24 through 45 years. Observational follow-up through 10 years in a subset of women in the base study, a cross-study immunogenicity analysis showing statistical non-inferiority of immune responses to quadrivalent vaccine in males, 27 to 45 compared to males 16 through 26, and extrapolation of these data to 9-valent vaccine in individuals 27 through 45. Also, grade for adult vaccination was presented to ACIP in October 2018, and the grade evidence tables included data for the bivalent and the quadrivalent vaccine, immunogenicity, safety, and efficacy in adults 27 through 45. The work group has updated the grade tables this month to include data from the new 9-valent immunogenicity and safety trial in women 27 through 45. And again, you'll hear that in the next presentation. Now, to end, I want to mention some aspects of the global landscape for HPV vaccines, and this was also discussed briefly in October 2018. This slide shows countries with HPV vaccine in the National Immunization Program as of early 2019. 96 countries, or just under 50% of all countries, had introduced HPV vaccine, but most of the countries with the highest burden of cervical cancer have not yet introduced. There is currently a global HPV vaccine demand-supply imbalance, which is outlined in this World Health Organization publication. As background to this, the World Health Organization issued vaccination recommendations for the first time in 2009 for a single age cohort of girls. In 2016, this recommendation was modified to include multi-age cohort vaccination for girls 9 through 14 in the first year of vaccine introduction. This was for greater and faster impact of the vaccination program. This recommendation, along with more country interest in introduction of HPV vaccine, has increased demand. Gavi funding for HPV vaccination for eligible countries started in 2012. Gavi procures bivalent and quadrivalent vaccines. The current HPV vaccine demand-supply imbalance is projected to last 3 to 5 years until there is more manufacturing capability by the two current manufacturers, and other manufacturers in late stages of vaccine development can bring their products to market. This will delay introduction in some low, middle, and high-income countries and prevent multi-age cohort vaccination, and there's no shortage that's been anticipated in the United States. The global HPV vaccine supply was discussed at the World Health Organization SAGE meeting in October of last year, and the following statement was included in their published SAGE report. Concerned about the impact of constrained HPV vaccine supply forecast until at least 2024, SAGE urged a more equitable distribution of available doses be encouraged to ensure optimal global public health access to vaccine. And there are ongoing discussions at WHO and Gavi about vaccination strategies and allocation of vaccine during the projected shortage. Now, this short update on the global vaccine supply, demand-supply imbalance is presented to ACIP today for general awareness, and because some work group members considered this in discussions of policy options for vaccination of adults older than age 26. And to end, I just want to mention again that we're addressing two policy questions: harmonization and vaccination of adults older age 26. And I'd like to thank all of the work group members who really participated in many, many work group calls over the past year.
Thank you very much for that presentation. Let me call on Dr. Luxemburg to discuss 9-valent HPV immunogenicity and safety trial in mid-adult females, please. Dr. Luxemburg.
Thank you very much. I'd like to thank the opportunity to speak. So thanks to Dr. Merkowitz and to the HPV work group. We'll talk today about, and it's going to be a brief presentation about what we presented to the ACIP, a year ago, and also about our new clinical trial. It's called Protocol 4, and it's the trial of the 9-valent vaccine in women 27 to 45 years of age. So we presented previously data to the work group, and I'd like to, in the next 3 slides, to go briefly through some of the background information. In terms of clinical trial information, we showed you that the 4-valent vaccine is highly efficacious to prevent infection and disease, regardless of age, essentially. The age tested were 16 to 45 years of age, and there was high efficacy over that entire age range. It's a very consistent feature of clinical trials. And also we showed that the protection was durable. And we have in women 27 to 45 years of age, a protection that lasts at least 10 years in clinical trials. Given that regulatory agencies have concluded that the data from the 4-valent vaccine can be extrapolated to the 9-valent vaccine, and this is based on the fact that the 2 vaccines are manufactured using the same process, that they share the same VLP for at least 4 types, and importantly that all efficacy and immunogenicity bridging studies have been successful between the 2 vaccines. So based on that, there has been agreement that the data with the 4-valent vaccine are also applicable to the 9-valent vaccine. And based on that, regulatory authorities have agreed to license the 9-valent vaccine in adult older than 26. And you can see that it's different according to the country. So starting with the US, the FDA has granted an increase of the upper age of the indication from 26 to 45, and that was last year in October 2018. And in other countries such as Canada and Australia, there was already an indication up to age 45 in girls and women. And in the European Union, we have also an indication starting from age 9 years without upper age limit in both genders. In addition, the European Medicine Agency asked for a clinical trial. It was a post-marketing commitment, which is to document the safety and immunogenicity of the 9-valent vaccine in women 27 to 45 years of age, with a comparison to women 16 to 26 years of age. And that's going to be the object of this presentation. And before going to the data from Protocol 4, I just would like to show you this slide, which is a slide of published data, but it's good to put the data in context. These are data from the pivotal efficacy study of the 4-valent vaccine, which show you that for 2 important clinical endpoints, one endpoint of infection and cervical disease and condyloma, the other of cervical cytological abnormalities, show a high efficacy, certainly, and show also a similar efficacy between 24 to 34 years of age and 35 to 45 years of age in study participants. And so there is really no statistical difference between the efficacy in these 2 ages for 2 different endpoints. There is a substantial number of endpoints accruing in the placebo group, so showing that there is infection and cytological abnormalities. So something important to keep in mind when we are going to look at the data from Protocol 4. So second part of my presentation, we are going now to Protocol 4, it's a study that includes women 16 to 45 years of age. They are split into two cohorts, 16 to 26 and 27 to 45. It's an open label study. Everything received the 9-valent vaccine. And the goal is to look at immunogenicity of a 3-dose regimen at month 7. We also look at the safety in the same way it's been looked at in other studies of the 9-valent vaccine. And the primary objective is to demonstrate non-inferiority of GMTs at month 7, 1 month after the last dose, for the 7 high-risk types. The non-inferiority criterion requires less than a 2-fold decrease in adult women compared to young women. This study design was agreed with the regulators. And so without further ado, let's go to the analysis of the primary objective. This slide shows you in green the immunogenicity assessed by GMT for the 16 to 26 years old, and in orange for the adults 27 to 45 year olds. Similar to what we've seen with the quadrivalent HPV vaccine, there is a trend to lower GMT in adults, but the GMTs are pretty high. There is strong immunogenicity. The GMT ratios are approximately 0.7, which is similar to what we've seen also with the quadrivalent vaccine. Looking at the 95% confidence interval of the GMT ratio, which is under, you can see that the lower bound is approximately 0.6 or greater than 0.6 for all the types. The non-inferiority criterion required that the lower bound be greater than 0.5. So we met the non-inferiority criterion, and the study is a success from this standpoint. This slide shows you that the vaccine is highly immunogenic. Here we are looking at the 9 types, and the seropositivity rates at month 7 are greater than 99% for all participants and for all HPV types. This slide looks at immunogenicity by age strata, so looking at 16 to 20, 21 to 26, 27 to 36, and 37 to 45-year-olds. And it shows you that the immunogenicity is very robust, regardless of the age. There is a trend to decrease GMT, which is common with many vaccines and has been seen also with the 4-valent vaccine previously. And as I mentioned earlier, efficacy is always high, regardless of age. Looking at safety now, this slide compares general safety between the 2 age groups, and there is really no substantial difference. Most adverse events are injection site adverse events, and there are thankfully no vaccine-related serious AE and no vaccine-related death, or no death at all. Looking at injection site adverse events, which are the most common, we have obviously pain, swelling, and erythema, which are the most common. This slide shows you that the frequency of the adverse events at the injection site are similar between the 2 age group, and there is no statistical difference as shown in the last column. So my last slide is a conclusion slide. We've looked at women 27 to 45 years of age in previous clinical trials, and this is shown on a backup slide. All these women are susceptible to infection by some of the types in the 9-valent vaccine. At baseline, in the pivotal efficacy study of the quadrivalent vaccine, more than 80% of them were PCR negative for all 9 types, and none of them were PCR positive to all 9 types. So there is benefit here, and that's why you are running these studies. I reminded you that the quadrivalent vaccine is highly efficacious regardless of age, in the range of 16 to 45 years. provides durable protection for at least 10 years. And today we've showed you that the 9-valent vaccine is highly immunogenic, that it induces antibody response that are non-inferior to that in young women. And so together with the efficacy data of the 4-valent vaccine, these results support the efficacy of the 9-valent vaccine in women 27 to 45 years of age. The safety was acceptable and the vaccine was generally well tolerated. And so the overall conclusion here is that collectively all these data support the clinical benefit of the 9-valent vaccine in 27 to 45 years of age. And I would like to thank you for your attention.
Thank you for your presentation. Next, I'd like to invite Dr. Chesson to discuss the overview of health economic models for HPV vaccination in mid-adults. Dr. Chesson.
Good morning. This slide illustrates the history of the health economic presentations that have been given to ACIP regarding mid-adult vaccination. Back in October, there was a summary of 3 models which illustrated great differences in the model results. Subsequently, we asked the CISNET cancer modeling group if they could help us understand these differences. In February, there were 2 health economics presentations. Dr. Brisson presented the HPV advised model, and there was a summary presentation of 5 modeling results, including 2 from the CISNET group. Since the February meeting, all of the models have completed the CDC economic review process, and we now have a better understanding of the differences in the model results. Today, I will give an overview of the 5 available models before showing results from these models that can inform the 2 policy considerations today listed here. And then I briefly will discuss some of the reasons for the differences in the model results. This slide shows the 5 models that are available to us to inform mid-adult HPV vaccination policies in the U.S. And this slide has the required conflict of interest statements for health economic models presented to ACIP. There are a lot of similarities across the models. All models include a wide range of health outcomes that can be prevented by HPV vaccination. All models incorporate current estimates of the medical treatment costs of HPV-associated cancers. And all models are dynamic, that is, they account for herd effects, and thus they take into account the herd effects of the existing vaccine program on mid-adults. All of the models examine a long time horizon, but they exclude productivity costs from the analyses. There are a lot of key differences across the models as well. The models differ in structure and in how they were calibrated to fit available data. The models also differ in assumptions regarding cervical cancer screening, vaccine uptake, and natural history parameters, such as the degree of natural immunity after infection and clearance. The models also differ in how HPV transmission dynamics are characterized. This table just shows examples of how the models differ in structure and in calibration. Regarding calibration, one important point is that the HPV advised model uses the 50 best fitting parameter sets, whereas the other models use a single best fitting parameter set. This table shows how the models differ in natural immunity assumptions. I will not go over all these assumptions in detail. What I just wanted to show is that the models differ in terms of the percent of people who have natural immunity after infection and clearance, and also in the degree and duration of this protection. Before showing the results for mid-adult vaccination, I just want to show what the models tell us about the cost effectiveness of the current program. All 5 models give a relatively favorable cost effectiveness estimates. The cost per quality adjusted life year, or QALY, gained by vaccination ranges from less than 0 in the HPV advised model, indicating that the program is cost saving, to just under $35,000 in the CISNET Harvard model. Before showing the results, I also want to clarify the comparisons that were made to inform the policy considerations for today. For harmonization through age 26 years, the models looked at vaccination through age 26 years versus the current program. And for vaccination of adults older than 26, there were two key comparisons that were made. First, the models looked at expanding vaccination to 30 years old versus staying with the current program. And the models also looked at vaccination through age 45 years versus the current program. The modelers examined a wide range of other scenarios, such as incremental analyses of increasing the cutoff age from 30 to 35 and 40, but I will not be showing those results today. I will begin with results for harmonization of catch-up through age 26 years, focusing primarily on results from the HPV advised model. This table shows the estimated number needed to vaccinate to prevent one case of disease in the HPV advised model. The estimates for the current program are shown on the top row, in which the estimated number needed to vaccinate is 9, 22, and 202 for warts, SIN2-3, and HPV-associated cancers. And as you can see, for the expanding mid-adult harmonizing at age 26, there are three sets of results shown from the HPV advised model. The first shows the result when all 50 parameter sets are applied, and then results are shown when using the 22 sets that have a faster progression from infection to cancer and lower natural immunity, and then results from the 28 parameter sets with slower progression and higher natural immunity. And as you can see, the results are more favorable for harmonization at age 26 when using the parameter sets with faster progression and lower natural immunity. This table shows the cost effectiveness of harmonization of HPV vaccination. As shown before in the first row, the HPV advised model predicts that the current program is cost saving. When the analysis is limited to the parameter sets with faster progression and lower natural immunity, the cost per quality gained is roughly $178,000 for harmonization at age 26 and over $400,000 for harmonization at age 30. When the analysis is limited to the slower progression and higher natural immunity scenarios, no cost per quality could be estimated for harmonization at age 26 because the model could not consistently find significant health benefits at the population level of this strategy. And in this scenario, the cost per quality gained by harmonization at age 30 was about $2.3 million. In terms of the estimated impact on the cost of the HPV vaccination program, the long-term costs are expected to only go up by about 5% or less based on estimates from the simplified transmission model under the uptake assumptions used in that model. Now I will move on to vaccination of adults older than age 26 years. This table shows the number needed to vaccinate to prevent one case of disease from the HPV advised model, again with the results for the current program shown on the top row. Again, there are three sets of results shown for vaccination of adults through age 45 years versus the current program. And as you can see, these are much higher than for the current program. For the results for using all 50 parameter sets, the number needed to vaccinate is roughly 40 times higher than the corresponding value for the current program. This table shows the estimated impact of HPV vaccination in terms of the percentage change in disease incidence. This was presented by Dr. Brisson in February. The blue line shows the impact of the current program, and the red line shows the impact when extending the current program to include mid-adults through age 45 years. And as you can see, the two lines are very difficult to distinguish from one another because there's very little incremental benefit at the population level of extending the vaccination program through age 45 years. For example, in the top right corner for cervical cancer, the model estimates that the current program over 100 years will avert about 650,000 cases, and then adding the mid-adult strategy through age 45 would avert an additional 3,000 cases. This table shows the cost effectiveness of vaccination of adults older than age 26 years for all 5 models. Note that there are 2 sets of results. The first row of results shows the cost per quality gained by extending vaccination through age 30 years versus the current program, and the next row of results shows the cost per quality gained by extending vaccination through age 45 years versus the current program. Just as a reminder, the HPV advised model uses results from the 50 parameter sets. However, if we limit it to the parameter sets that have the faster progression and lower natural immunity, the cost per quality gained is lower, as shown by the red boxes. And conversely, when we limit it to the parameter sets that have slower progression and higher natural immunity, we get higher cost per quality estimates. As noted in February, a distinguishing feature of the CISNET model results is that the cost per quality gained through vaccination through age 45 years is lower than through age 30 years, and this arises likely because of herd effects of the existing program on mid-adults. I want to point out that the estimate in the simplified model has changed since the February presentation. The simplified model now takes into account the ongoing HPV vaccination program, and the magnitude of this increase is consistent with what we expect based on the other models showing the importance of accounting for historic vaccination coverage. The estimates in the Merck model are a bit lower than presented in February, owing to a series of minor changes that are described in the footnotes. This slide lists a few of the identified factors that may account for some of the differences in the model results. These three factors were discussed in February, and in the interest of time, I will not go over these now, but will refer you to the supplemental slides for more information. The ACIP CDC economic reviewers asked the modelers to examine a set of results when using a standardized list of health economic parameters regarding medical costs, medical treatment cost of the HPV-associated outcomes, as well as quality of life assumptions. And these results were not available in February, but we do have them now. And this table shows the cost effectiveness of vaccination of adults through age 45 years versus the current program. The base case results in the top row are the same as I presented earlier, but what's added now is a bottom row showing the results under the standardized economic parameters. As you can see, there was a somewhat large relative increase in the Merck estimate. However, in terms of the absolute differences across the models, these parameters did not make that much of a difference. And one other factor I want to discuss today is one we've recently identified that may be accounting for some of the differences across the models, and this has to do with deaths from undiagnosed cancer. So in the Merck model, each year, in the absence of vaccination, there would be almost 10,000 deaths due to diagnosed HPV cancers. And this result's fairly consistent with the other models. Also in the Merck model, they estimate that about 24,000 deaths would be attributable to undiagnosed HPV cancer each year. And that works out to about 71% of the HPV cancer deaths being attributable to undiagnosed cases. And what this table shows is these results across the 5 models, beginning with the 71% that I just mentioned for the Merck model. With the exception of the CISNET model cervical cancer component, in which 16% of the cervical cancer deaths were attributable to undiagnosed cancers, none of the other models had undiagnosed cancer deaths in the analysis. And it's important to point out that the 71% value and the 16% value are outputs of these models, whereas the 0% values arise from assumptions of the modelers that there are no deaths due to undiagnosed cancers. The models get a lot of their data about cancer incidence from the cancer registries, and if the registries have good completeness, we don't expect there to be too many or a large number of deaths due to undiagnosed cancers. And as you can see by the quote here from the U.S. Cancer Statistics webpage, there is a fairly high degree of confidence in the completeness of the registry data. This table shows results from the Merck model regarding the cost effectiveness of vaccination through age 45 years versus the current program. The base case result that I presented earlier is shown on the top row. Then the results are shown when removing the benefits of preventing deaths due to undiagnosed cancer, which increases the cost per quality to just over $200,000. When simultaneously adding the standardized health economic parameters, the cost per quality increases to over $400,000. So undiagnosed cancer deaths do account for some of the differences across the model results, but this doesn't account for all the difference because even when we standardize assumptions regarding undiagnosed cancer deaths and health economic parameters, there are still some differences that continue across the models. So to summarize, the cost per quality gained by the current vaccine program is less than $35,000. It's cost saving in the HPV advised model. And in all models, adult vaccination is much less cost effective than the current program. However, there's differences in the cost effectiveness estimates across the models. Uncertainties in the natural history of HPV and in transmission dynamics preclude a precise estimate of the cost effectiveness of adult vaccination. However, we've learned that the models do seem more similar when we standardize assumptions regarding health economic parameters and deaths due to undiagnosed cancers. And in the context of the existing program, vaccination of adults older than age 26 would produce relatively small additional health benefits. For example, the number needed to vaccinate when looking at adults up to age 45 was about 40 times higher than that of the current program. So the cost per quality gained for harmonization of catch-up vaccination through age 26 years versus the current program is about $178,000 in the HPV advised model when using the more favorable parameter set. When using the less favorable parameter set, no cost per quality could be estimated because no significant gains in qualities could be estimated at the population level. So the results are not so favorable or unfavorable as to make a strong argument for or against harmonization through age 26 years. And for vaccination of adults older than age 26, the cost per quality gained by adult vaccination through age 30 years exceeds $300,000 in 4 of the 5 available models and is about $800,000 in the median of the 50 parameter sets in the HPV advised model. Similarly, the cost per quality of adult vaccination through age 45 years exceeds $400,000 in 3 of the 5 available models and exceeds $1 million in the median of the 50 parameter sets in HPV advised. Now I'll turn it over to the chair to see if we have time for comments from the modeling groups in attendance. And I want to thank the modeling teams for their contributions.
So I'd like to invite Merck, either Dr. Haupt or Dr. Luxemburg, to add additional comments, please.
Is that microphone not working?
Vaccination to 45 years old. I have only a couple of comments. The first comment is about the review process and the continuous refinement of the Merck model. I would like to thank Dr. Chesson and the CDC reviewers for a thorough review of the Merck model. They reviewed several lengthy documents, including dense mathematical equations and detailed results from many model scenarios during several rounds. They have asked several important questions and provided feedback that helped and will continue to help in refining the model. It is inputs and it is prediction. We will continue to refine the Merck model and it is prediction, and we'll continue to conduct additional analysis to address the uncertainty in the natural history, as well as health economic inputs and other important inputs. The second comment that I wanted to make is that the model results are still different and are not aligned, and this requires further investigation. The models are aligned when evaluating the current program of vaccinating younger cohorts, but they exhibit a wide variation in results when vaccinating older cohorts. Our understanding of differences in models has improved, but we still do not fully understand what accounts for the major differences. Because they are simplification of a complex reality, all models have limitations. We think it is important that all modeling groups work together to fully understand what might be driving the major differences in model results. This would include sharing equations, input, and other technical details about their models and harmonizing critical assumptions and inputs. We would welcome any further input from the CDC team and any opportunity to work with other modeling groups, including participation in comparative modeling exercises and face-to-face meetings. This would greatly help decision makers, not only in the US, but in jurisdictions around the world, to accurately assess the public health impact and the true economic value of expanding vaccination to 45 years old. Thank you.
Thank you for those comments. Now I'd like to open it up to the voting members to see if there are any questions that they wish to have addressed. Dr. Moore.
I had just a clarifying question for Dr. Chesson, and that was on the number needed to treat. I'm pretty sure I have the assumption correct, but I want to make sure on, like, for example, slide 13, the incremental difference in the new versions is the number needed to treat among those currently not recommended. Is that correct? So when you go to
the current program versus no vaccination, then and you move to the other higher numbers, those higher numbers represent, for example, the men 22 through 26 who are not currently recommended for routine catch-up, or is that looking at the number needed to treat across the whole cohort, adding in that small number of men? I wasn't sure which one it was.
It's closer to the interpretation that you had, in that it focuses on the benefits of vaccinating the men in this age group, but it looks at the additional number vaccinated when we include these men and the additional number of cases averted. So these cases could be averted through herd effects of vaccinating these men, but it is based on the benefits of extending the vaccination to include these men.
Okay, thank you.
Thank you.
Are there any other, Dr. Hunter?
So I was wondering if the Canadian representative could comment on, it sounds like the 9-valent HPV vaccine is indicated up to age 45 in Canada also, and just if you could comment on whether your body had deliberations on this and decided to also recommend it.
So this recommendation was done a while back, not looking at the cost effectiveness. So we didn't delve into all the details that you have here. It was more of a permissive indication than a fully publicly funded program.
Go ahead, Dr. Hunter.
A follow-up question, if I could. I know the provinces get to decide province to province. Did different provinces have different approaches?
We actually do. If you look at, I'll take Quebec because that's where I live. So in the province of Quebec, actually, we are completely moving toward a mixed schedule and not providing public coverage up to even 26. It's really based on the like the teenagers and the fourth graders. But we don't have a publicly funded program for the 26 to 45 in Quebec, and most of the provinces don't have that either.
Any other comments from that? Dr. Stevens.
Just a clarification on the undiagnosed cancers in two of the models. Can you comment? I mean, I'm trying to understand where those data originally came from, if it doesn't look like they're real.
Those estimates of having deaths due to undiagnosed cancers are outputs of the model. They're not inputs into the model based on parameter values observed. So what perhaps the Merck modeler could come back and explain how they arrives at these in their model. But I just want to clarify, it's an output of the model, not an input.
Would Merck like to comment?
Hi, I'm Alamin Al-Basha. I'm representing the modeling group from Merck. So in all the models, death is an outcome. It depends on assumption regarding the natural history, as well as many factors, including the inputs on transmission, progression, diagnosis and prevention efforts. In the Merck model, when we calibrated the model, which meaning that by varying certain input to match outcome data, we match to HPV age-specific and HPV type-specific prevalence. We match to data on cervical cancer incidence by age from the registry, but we only started looking at the overall number of deaths that occurs if you don't vaccinate or if you vaccinate. So the comment that Dr. Chesson mentioned that the registries capture all deaths, that is true if somebody is diagnosed. But the registries, by definition, only include individuals who are diagnosed with cancer. So in our model, we also account for the fact that somebody can be dying from cancer while not diagnosed. We are actually looking at data from more cancer mortality statistics to make sure that by varying setting our inputs in the model, we get to match the overall deaths from cancer, whether it is diagnosed or not diagnosed. We think that deaths can happen from undiagnosed cancer.
Thank you for those comments. Are there any other comments or questions from the voting members? From the liaison members, are there any questions related to the previous presentations before I move on?
Okay, before we move on to the next presentation, I just want to make two announcements. The first was, in case you haven't noticed, there are a number of cameras in the room, along with the CDC webcams filming today's meeting. The cameras are being operated by the room are from members of the press and a crew of people doing a documentary. So if you have any concerns, please see the communications desk in the back of the room. I also I apologize for the microphone situation as much as possible, even though I know many of you can speak very loudly. If we can wait and get a microphone, because we are taking detailed minutes of the meeting and she needs to record through the microphones. So it would be really helpful, and I apologize for the inconvenience.
Thank you. Okay, no further comments or questions. Let's move on. Dr. Maties, on the evidence of to recommendation framework for HPV vaccine.
Good morning.
Check 1, 2.
Today I'll be presenting two evidence to recommendation summaries, one for each of our policy questions. First, the evidence to recommendations for harmonization of catch-up HPV vaccination through age 26 years. These are the elements of the ACIP evidence to recommendations framework. For each policy question, we discussed the PICO question and background, problem, benefits and harms, values, acceptability, resource use, feasibility, and balance of consequences before arriving at a policy option for ACIP consideration. For each of these criterion, we summarize the evidence and considerations and offer the judgments of the HPV vaccines work group. The first PICO question was, should catch-up HPV vaccination be recommended for primary prevention of HPV infection and HPV-related disease for all persons through age 26 years? The population is males aged 22 through 26 years, since that's the group for whom the recommendation would change. The intervention is catch-up vaccination with 3 doses of HPV vaccine. The comparison is existing HPV vaccination recommendations, and the outcome is primary prevention of HPV infection and HPV-related disease. ACIP routinely recommends HPV vaccination for adolescents at age 11 or 12 years. Catch-up vaccination recommendations apply to people who are not vaccinated at the routine age. Since 2006, ACIP has recommended vaccination for females at the routine age of 11 or 12 years, and catch-up vaccination for females through age 26 years. In 2011, ACIP added routine recommendations for males at age 11 or 12 years, with catch-up vaccination through age 21 years. And catch-up vaccination has also been recommended through age 26 years for men who have sex with men, including men who identify as gay, bisexual, or who intend to have sex with men, for transgender persons, and for persons with certain immunocompromising conditions, such as HIV. vaccination coverage has been increasing among U.S. adolescents, but remains low among young adults, and coverage in males is lower than coverage in females. In 2017, at least one dose coverage among 13 to 17-year-olds was 69% in females and 63% in males. For 22 to 26-year-olds, it was 51% in females and 15% in males. HPV is common in both women and men and causes over 33,000 cancers annually in the United States, including over 20,000 cancers in women and over 13,000 cancers in men. The existing HPV vaccination program for U.S. adolescents has the potential to prevent the majority of these cancers. However, it is uncertain how much HPV-related morbidity and mortality is related to new HPV infections acquired by men at ages 22 through 26 years. The work group feels that HPV-related disease is a problem of public health importance, and that preventing new HPV infections among 22 through 26-year-old males is probably of public health importance. Regarding desirable anticipated effects, efficacy has been demonstrated in this age group. Clinical trials have shown that HPV vaccines are effective against infection and related disease due to HPV types that recipients are not infected with at the time of vaccination. Additional benefit of vaccinating males in this age range would be small compared with the benefit of the existing program. The number needed to vaccinate to prevent one case of anogenital warts, CIN2+, or cancer is 9, 22, and 202, respectively, under the existing program. For expanding recommendations for males through age 26 years to harmonize catch-up vaccination across genders, the number needed to vaccinate would be 40, 450, and 3,260, respectively, in a subset of analyses in the HPV advised model with more favorable model assumptions for adult vaccination. As for undesirable anticipated effects, in 9-valent vaccine clinical trials, there were no serious vaccine-related events among males aged 9 through 26 years, and adverse events were generally less common among males than among females. HPV vaccines have an excellent safety profile based on large clinical trials and post-licensure effectiveness data. Over 100 million doses of HPV vaccine have been given in the United States. The additional benefit of vaccinating males in this age range would be small compared to the existing program. However, small desirable effects outweigh minimal undesirable effects of HPV vaccination, and thus the judgment of the work group is that this favors intervention. Full grading of recommendations, assessment, development, and evaluation, or GRADE, for use of quadrivalent and 9-valent vaccine in males have been publicly available since these ACIP recommendations were made in 2011 and 2015, respectively. For males through age 26 years, the grade evidence level or certainty of the evidence is 2 or moderate for benefits of quadrivalent vaccine and 3 or low for benefits of 9-valent vaccine, and 2 or moderate for safety of quadrivalent vaccine and 2 or moderate for safety of 9-valent vaccine. Regarding values and acceptability to the target population, a systematic review of 22 published studies found that the overall mean acceptability of HPV vaccine was moderate, at 57 on a 100-point scale. In the 9 studies reporting sexual orientation, there was no significant difference in acceptability between gay, bisexual, and other men who have sex with men, and heterosexual men. So does the target population feel that the desirable effects are large relative to undesirable effects? The judgment of the work group is probably yes. And is there important uncertainty about or variability in how much people value the main outcomes? The judgment is no important uncertainty or variability. Next, we consider acceptability to key stakeholders, including programs and vaccine providers. In a 2018 survey conducted by the Association of Immunization Managers, 51 immunization programs responded, and 50, or 98%, were in favor of harmonizing the recommended age for catch-up vaccination to include everyone through age 26 years. Reasons the majority of programs favored harmonization were easier to implement, easier to explain to patients, will simplify health department recommendations and guidelines, easier to explain to providers, facilitate reaching high-risk populations, to create equity between genders, and reduce the burden on healthcare providers. In a 2018 survey of primary care physicians, including pediatricians, family physicians, and internal medicine physicians, 93% were in favor of a change to harmonize the recommended age for catch-up vaccination to include everyone through age 26 years. And 27% agreed that current catch-up recommendations with different upper ages for males and females have caused challenges or confusion. Reasons the majority of physicians favored harmonization included simplify the vaccination schedule, easier to implement, easier to explain to patients, facilitate reaching high-risk populations, reduce burden on healthcare providers, and create equity between genders. The judgment of the work group is that yes, the intervention is acceptable to key stakeholders. For resource use, health economic analyses were conducted. In the context of the existing program for adolescents and catch-up, the incremental cost per collie gained for expanding male vaccination through age 26 years was $178,000 in a subset of analyses in the HPV advised model with more favorable model assumptions for adult vaccination. And although less cost efficient, absolute cost of vaccination would likely increase by less than 5% in the long term under the expanded recommendation. And these results are not so favorable or unfavorable as to make a strong economic case for or against harmonization through age 26 years. As for whether the option is a reasonable and efficient allocation of resources, the judgment of the work group is that this is uncertain. As a simplifying modification to an existing vaccination program, this intervention is considered feasible to implement. ACIP already recommends catch-up HPV vaccination for some people aged 22 through 26 years, including those who are female and certain special populations. And a simplified adult immunization schedule is expected to be easier to explain and to remember. So this option is considered feasible to implement. After weighing the evidence, the judgment of the work group about the overall balance of consequences is that desirable consequences probably outweigh undesirable consequences in most settings, and the work group feels there is sufficient information to move forward with a recommendation at this time. Based on the evidence and considerations here, the policy option for consideration is to recommend the intervention. And the next presenter, Dr. Markowitz, will offer the proposed recommendation text. In the second half of this presentation, I will present the evidence to recommendations for HPV vaccination of adults older than age 26 years. Our second PICO question was, should catch-up HPV vaccination be recommended for primary prevention of HPV infection and HPV-related disease for all persons ages 27 through 45 years? The population here is persons aged 27 through 45 years. Intervention is catch-up vaccination with 3 doses of HPV vaccine. Comparison is persons aged 27 through 45 years with no catch-up HPV vaccination. And the outcome is primary prevention of HPV infection and HPV-related disease. As you know, HPV is a common sexually transmitted infection. Persistent HPV infections can develop into cancers, usually several decades later, and vaccination against HPV is recommended to prevent new HPV infections and subsequent disease. In October 2018, based on results from quadrivalent vaccine clinical trials in women through age 45 years and bridging immunogenicity and safety data in women and men, the Food and Drug Administration approved 9-valent vaccine for use in U.S. women and men through age 45 years. Over 33,000 cancers are caused by HPV annually in the United States. including cervical, vaginal, vulvar, penile, anal, and oropharyngeal cancers. And again, the existing HPV vaccination program for U.S. adolescents has the potential to prevent the majority of these cancers. It is uncertain how much HPV-related morbidity and mortality is related to new HPV infections acquired at ages 27 through 45 years. The mean age of acquisition of causal HPV infections for cancers is unknown, but is estimated to be decades before cancer is diagnosed. HPV incidence is highest among people in the age range of teens to early 20s. And first HPV infections are acquired soon after first sexual activity, so most sexually active adults have been exposed to HPV already. Nevertheless, at any age, having a new sex partner is a risk factor for acquiring new HPV infections. Exposure to HPV decreases among older age groups as the percentage of people reporting a new sex partner within the past year is lower in older age groups than among younger age groups. The existing U.S. HPV vaccination program has resulted in significant declines in prevalence of vaccine-type HPV infections, anogenital warts, and cervical precancers, and declines have been observed among both vaccinated and unvaccinated persons, suggesting protective herd effects. And these are the most recent national data on prevalence of HPV infections under the existing vaccination program. Compared to the pre-vaccine era, 2013 to 16 prevalence of quadrivalent vaccine-type HPV infection declined 86% from 11.5 to 1.8% among 14 through 19-year-olds, and declined 71% from 18.5 to 5.3% among 20 through 24-year-olds. And declines seen in older age groups were not significant, but over time we expect to see further declines in the older age groups as vaccinated women age into these groups. The work group agrees that HPV-related disease is a problem of public health importance. However, the amount of HPV-related disease that could be prevented by vaccinating 27 through 45-year-olds is small compared with the amount of disease that can be prevented by vaccinating at younger ages. And preventing new HPV infections among 27 through 45-year-olds is of uncertain public health importance. Clinical trials have shown that HPV vaccines are effective against infection and related disease due to HPV types that recipients are not infected with at the time of vaccination. In the Future 3 trial of quadrivalent vaccine in adult women, against a combined endpoint of persistent HPV infection, extragenital lesions, and or CIN1+, per protocol efficacy was 88.7%, with a confidence interval of 78 to 95%. Intention to treat results were lower since these included women with previous HPV exposures and prevalent HPV infections at baseline even before they were vaccinated. And the intention to treat efficacy was 47.2%, with a confidence interval of 33 to 58%. And in the 9-valent vaccine trial presented today by Dexter of Luxembourg, antibody titers were non-inferior in women aged 27 through 45 years compared to women aged 16 through 26 years, and over 99% of women in both groups seroconverted to all 9-valent vaccine types. The desirable anticipated effects vary. HPV vaccines are most effective when given before exposure to any HPV. Population benefit of adult vaccination would be minimal in the context of the existing program, yet some individuals in this age range might be able to benefit from vaccination. Recall that under the existing program, the number needed to vaccinate to prevent one case of anogenital warts, CIN2+, or cancer is 9, 22, and 202, respectively. For expanding vaccination to include adults through age 45 years, the number needed to vaccinate would be substantially higher at 120, 800, and 6,500, respectively, according to a subset of analyses in the HPV advised model with more favorable model assumptions for adult vaccination. There is abundant evidence for safety of HPV vaccines. In 9 clinical trials of 9-valent, quadrivalent, or bivalent HPV vaccine in adults older than age 26 years, there were few serious adverse events and no vaccine-related deaths. Yet, from a public health perspective, some workgroup members felt that adult vaccination might detract from the adolescent vaccination program, which remains the main focus for HPV prevention. Unanticipated harms could occur if vaccination of previously exposed or ill adults were to cloud data on vaccine safety or efficacy, or if communication messages were to focus on sexual transmission rather than HPV disease prevention. So the judgment of the workgroup is that desirable anticipated effects vary compared with the benefit of the existing HPV vaccination program for adolescents and young adults through age 26 years. The additional population level benefit of vaccinating people aged 27 through 45 years would be minimal. Yet, some individuals in this age range might be able to benefit from vaccination against HPV types they have not yet encountered. Undesirable anticipated effects are also minimal given abundant evidence for safety of HPV vaccines, and we want to acknowledge that there could be concerns about potential undesirable, unanticipated effects on the program as well. As for whether the desirable anticipated effects outweigh the undesirable anticipated effects, the judgment of the work group is that this is unclear. Full grade tables with detailed assessment of the certainty of the evidence were presented to ACIP in October 2018. And the only change is that we are adding the results from the 9-valent vaccine observational trial that was presented today. So the number of studies has increased by 1 for immunogenicity and safety, but the overall certainty of the evidence is not changed. The certainty of the evidence on benefits based on 3 randomized controlled trials of quadrivalent or bivalent vaccine efficacy and immunogenicity, and 6 observational trials of immunogenicity, was grade evidence level 2 for moderate quality evidence. And the certainty of the evidence on harms based on 5 randomized controlled trials and 4 observational trials was also grade evidence level 2 for moderate quality evidence. So the certainty of the evidence was level 2 or moderate for both effectiveness and safety of the intervention. And note that the evidence presented in the grade tables has to do with individual level outcomes on vaccine safety and effectiveness, and outcomes in grade do not speak to population level outcomes or any programmatic concerns. Regarding values and acceptability to the target population, in 9 published studies of adults, acceptability varied across studies, yet overall was moderate to high. Acceptability was higher when vaccine was assumed to be free and or a healthcare provider made a recommendation. Acceptability varied by study population and methodology. Does the target population feel that desirable effects are large relative to undesirable effects? The judgment of the work group is probably yes. And is there important uncertainty about or variability in how much people value the main outcomes? The judgment is possibly important uncertainty or variability. For acceptability to key stakeholders, we note that there are no recently published data assessing U.S. stakeholder acceptability of routine HPV vaccination among 27 through 45-year-olds. However, vaccines for other conditions are routinely given to adults in this age range. In a 2019 survey about HPV vaccination recommendations based on shared clinical decision-making for individuals, among 45 immunization programs, the majority, 27 programs or 60%, anticipated that it would be either very challenging in red or somewhat challenging in yellow for immunization programs to communicate a recommendation for clinical decision-making to vaccine providers in their jurisdiction. And another 16 programs, or 36%, said it would be not challenging. Almost half, 19 programs, or 42%, thought it would be either easy in green or somewhat easy in yellow for vaccine providers to determine patients in this age group who might benefit from vaccination, while another 19 programs, 42%, said it would be not easy. And most, 31 programs, or 69%, anticipated challenges to implementing such a recommendation. It is uncertain whether this amounts to an option acceptable to key stakeholders. 5 health economic models of HPV vaccination in the United States were reviewed. In these models, the cost-effectiveness ratio for the current HPV vaccination program ranged from cost saving to about $35,000 per QALY gained. In the context of the existing program, expanding vaccination to adults through age 45 years would produce relatively small additional health benefits and less favorable cost-effectiveness ratios. For example, the incremental cost per QALY for also vaccinating adults through age 30 years exceeded $300,000 in 4 of 5 models. Variation in results across models was due to factors such as uncertainties about HPV natural history, as you heard from Dr. Chesson. Globally, there is an HPV vaccine shortage as production capacity is not adequate to meet demand currently. The demand-supply imbalance is expected to last for the next 3 to 5 years. In some countries, including those with Gavi and UNICEF support, national introductions and multi-age cohort vaccination are unable to proceed due to lack of vaccine availability. Although no domestic vaccine shortage is anticipated, some workgroup members had serious concerns about HPV vaccination recommendations being extended to 27 through 45-year-olds in the United States in this context. As for whether this option is a reasonable and efficient allocation of resources, the judgment of the workgroup was probably no. Delivering any adult vaccination can be challenging in the United States. Programs and funding for adult vaccination are not available in all jurisdictions, and adult immunization is performed primarily in the private sector. For shared clinical decision-making, identifying individuals likely to benefit for adult HPV vaccination could be challenging. Some vaccine providers do not regularly assess sexual behaviors. However, in a 2015 survey of obstetrician gynecologists, 81% reported that they already stock and administer HPV vaccine. Regarding health disparities, in general, it is not clear whether any recommendation for HPV vaccination in this age range would lead to greater uptake among individuals who are likely versus unlikely to benefit. Some workgroup members felt that recommending vaccination in this age range might reduce health disparities by increasing access to vaccination among adults with health insurance coverage. On the other hand, other workgroup members felt that recommending vaccination in this age range might enhance health disparities, as underinsured adults would be less likely to have access to vaccination since states have limited funds for adult vaccination programs. The overall judgment of the workgroup is that shared clinical decision-making for adult vaccination is probably feasible to implement, although there were a number of uncertainties about its potential consequences. After weighing the evidence, the judgment of the workgroup is that the balance between desirable and undesirable consequences is closely balanced or uncertain. Taking into account ACIP's role in providing timely guidance for vaccines with an indication from FDA, the workgroup would like to move forward with a recommendation. The HPV vaccines workgroup was unanimous that HPV vaccination should not be routinely recommended for 27 through 45-year-olds. A majority felt that ACIP should recommend the intervention for individuals based on shared clinical decision-making, while a large minority felt that ACIP should not recommend the intervention in this age range. Thus, 2 policy options are presented to ACIP for consideration. And in the next presentation, Dr. Markowitz will offer the proposed recommendation text for both of these options. And this concludes the evidence to recommendations presentations. I'd like to acknowledge all of the workgroup members and CDC contributors, and thank you very much.
Thank you for that excellent summary of the ETR. And now Dr. Markowitz will again take the podium and speak on the workgroup considerations and proposed efficacy policy options.
So to end this session, I will review the proposed recommendation text for the policy options that will be voted on in the afternoon session. As you heard from Dr. Midas, there was consensus on the workgroup for the first policy issue regarding harmonization of catch-up through age 26 years, and the consensus of the workgroup is recommend the intervention. This is the current text for routine and catch-up vaccination. The proposed recommendation text would, of course, not change the routine recommendation, but would simplify the catch-up recommendation. And the proposed recommendation text is in bold here. It would state, ACIP also recommends catch-up vaccination for persons through age 26 years who are not adequately vaccinated. Due to limited length of our policy notes, there will be several footnotes in the policy note referring to past recommendations. Specifically for this sentence, there'll be a footnote about the definition of adequately vaccinated. Just to remind everyone, adequately vaccinated, this will say definition of persons considered adequately vaccinated or unchanged from prior recommendation. And this is the footnote, which will refer to 2016 policy. The text from that policy states that the appropriate schedule, either 2 or 3 doses based on age at initiation of vaccination with any vaccine, any HPV vaccine, is considered adequate vaccination. I want to mention that text in other sections will also be impacted by the proposed harmonization text. For example, in special populations, there's current text for men who have sex with men and transgender persons stating recommendations for vaccination through age 26 years, and this would no longer be needed. Similarly, for medical conditions, there is text about catch-up through age 26 years for persons with immunocompromising conditions, and this would no longer be needed. And for simplicity, the work group is proposing a combined section header and one sentence that would read, the above recommendations for routine and catch-up age groups and for individuals older than the catch-up age group. And we haven't gotten to that section yet, but this wording would fit here. Also apply to MSM, transgender people, and people with immunocompromising conditions. Now I'm just going to pause here. And again, here is the proposed text for harmonization for catch-up that the ACIP will be voting on in the afternoon. ACIP also recommends catch-up vaccination for persons through age 26 who are not adequately vaccinated. And I'll just move on in the interest of time to the second policy question, which is vaccination of adults older than age 26. 2 options, as you heard, are proposed by the work group. Recommend for shared clinical decision-making, which is the majority option, or do not recommend the intervention, which is the minority option. The proposed recommendation text for the majority and minority opinions. For the shared clinical decision-making, ACIP recommends catch-up vaccination based on shared clinical decision-making for adults ages 27 through 45 who are not adequately vaccinated. HPV vaccines are not licensed for use in adults older than age 45 years. And again, there will be a footnote defining adequately vaccinated. And for the do not recommend intervention, the proposed text is ACIP does not recommend vaccination for adults older than age 26 years. There was a variety of discussion on the work group, and you heard some of these in the evidence to recommendations framework. I think maybe in the interest of time, I will just go through these very quickly. Or maybe I will not even go through these. I think you heard a lot of these. I want to leave time for discussion, but you have those. These are for shared clinical decision-making, and also the opinions of people who felt that there should not be a recommendation. I want to mention that the work group also considered the challenges of a shared clinical decision-making and have drafted some considerations that might be helpful for vaccine providers. And these could be included in a policy note if there is a recommendation for shared clinical decision-making. And these are listed on these slides. HPV is a very common sexually transmitted infection, although new infections are most commonly acquired in adolescence and young adulthood. Some adults are at risk for acquiring a new infection. Ideally, vaccination should be given in early adolescence. Vaccination before exposure to HPV through sexual activity will result in the greatest efficacy. Efficacy is high among people who have not been exposed to HPV, and efficacy is lower among people previously exposed to HPV vaccine, type HPV, likely including adults who are considered to be at high risk for HPV-related disease, given multiple lifetime sex partners and or certain immunocompromising conditions. Most sexually active adults have already been exposed to some types of HPV, although not necessarily all of the types targeted by vaccination. At any age, having a new sex partner is a risk factor for acquiring a new HPV infection, and no clinical antibody test can determine whether a person is already immune or still susceptible to any given HPV type. People who are in a long-term mutually monogamous sexual relationship are not likely to acquire a new HPV infection. And vaccines are prophylactic. That is, they don't prevent new HPV infections and do not prevent, that is, they prevent new HPV infections. They do not prevent progression of HPV infection to disease, decrease time to clearance of HPV infection, or treat HPV-related disease. And finally, just to getting back to the wording that will be open for a vote this afternoon. The proposed recommendation text for vaccination of adults older than age 26 for shared clinical decision-making and for do not recommend the intervention are listed on the slide. And with that, I will open it up for discussion.
So this topic is now open to discussion to the work group members. ACIP members. Dr. Moore, please.
Thank you. Thank you very much for. Hey, it's working great. Thank you very much for this thorough discussion. And I first of all share the work group's position around harmonization of the schedule through age 26. But the concerns about supply with the older groups, actually, I recognize there are individuals who could benefit from this vaccine. And I understand that there's a statement that there's no shortage now domestically, but the expansion of this recommendation to potentially include millions and millions more Americans, I've become sensitized to supply issues based on recommendations, and I'd like to learn more about that supply question because that gives me great pause. I would not want to do anything that would compromise in any way the supply access for our priority populations of the preteen and adolescent population. So to say globally there's a large shortage, but domestically there's no problem, we can expand this to tens of millions of other persons. The question that I'm wondering about at this point is, should we consider deferring the age 27 to 45 year question and remain silent for a few years until supplies have stabilized and we can be more confident that the decisions about this age group will not adversely affect access among priority populations in preteens and adolescent, where we already know there's great benefit that's been demonstrated? I don't know whether you're able to answer that or if someone from Merck would need to.
Well, the work group did hear a presentation from the manufacturer because of concerns, similar concerns, but I'll invite, if I can, invite someone from Merck to make a comment.
Can I ask a question, Kelly, before you ask Merck? Just because I want to make sure I understand. Your concern is not about the first harmonization piece and supply issues. Your concern is about this language, the second piece.
The second piece. The concern is about the 27 to 45 population expansion and whether domestic supplies could really support that.
Dr. Haupt, please, from Merck.
Hi, good morning. Hi, this is Rick Haupt. I'm with Global Medical Affairs at Merck. I think it's really important to talk about the global supply in the context of the discussion this morning. So first of all, we recognize that we have an imbalance in the demand and supply for Gardasil globally, and we take it very seriously. As Dr. Markowitz mentioned earlier, HPV vaccine recommendations and goals have changed quite dramatically in the last few years, and there have been new indications, new recommendations, or expanded use of the vaccine in many countries around the world, which have created an unprecedented demand on the Gardasil supply. So as part of Merck's global commitment to support global public health, we are making substantial investments in capital, investments to improve that supply. It's going to take a few years to be able to manage that, but in the short term, we're working with countries around the world to ensure that we can provide the supply adequately and equitably across both high and low resource settings. Now, as it pertains to the United States, we had fully anticipated the recommendations that were being discussed today in terms of the harmonization through age 26, as well as potential recommendations for shared clinical decision-making in the 27 to 45-year-old, and have supply to be able to manage those recommendations if voted on today. And I think it's important to note, particularly in the 27 to 45-year-old, as we know, there are individuals in that age group who remain susceptible to one or more of the HPV types that are in Gardasil 9. And there are many individuals who are at risk for new infections in this age group. So a shared clinical decision-making recommendation would be an appropriate recommendation to allow individuals the opportunity to have access to the vaccine so that they can be protected from HPV-related disease, including potentially cancer. So we again, from specifically, Dr. Moore, to your question, Merck has anticipated the supply demand that could come with these recommendations and are able to support that in the United States.
Thank you. Any other questions from the voting members? Etcheng.
So just wondering if when FDA approves a vaccine, don't it automatically means that the clinicians can adopt the shared decision making? And that's what as a clinician that I would do once that vaccine is FDA approved. So when I think about ACIP role, I think of it differently from what the FDA approval have done, which is give us the power as clinicians to utilize the shared decision making. So if that is the case, then ACIP role is a little bit more different from that FDA role. And we should consider all the other things that are public health importance. And from what I'm hearing from all the presentation, and talking about that there is an uncertain public health importance of expanding this vaccine from 26 to 45, which is a public health, one of the things ACIP role is different from the FDA role. So if that is the case, what is the policy implication, policy difference if we said ACIP meets and recommends shared decision making? That's already there with FDA approval, except the idea about who pays for the vaccine, which is the issue in this case. Because if it's shared decision, if we say we don't recommend it, it's still available for the physician to use the shared decision making, but it won't be paid for. I just want to make sure, is that the only difference?
That is a correct, and it is basically a correct interpretation. If a vaccine is licensed by FDA, it can be an individual can have a discussion with the provider and make a decision about whether or not they want the vaccine. And if it did not have an ACIP recommendation for even shared clinical decision making, it would not be covered by insurance, is my understanding. Amanda might want.
Yeah, I just think that this is complicated, and I think that this space that we're in now, where we're going to be with more than one vaccine today, is something that we need to kind of step back from and think about in the context of all of the clinical decisions that are shared between a clinician and a patient. So outside of just vaccines, there are multitudes of things that are in that space. I think the problem here is that if ACIP stays silent among certain cadres of clinician, it is interpreted as ACIP is basically thinking that there shouldn't be a conversation, even though you're right. In fact, a clinician can have a conversation with the patient about the vaccine, regardless of whether it's actually licensed for that age group anyway. But there is an interpretation by clinicians, I think, of silence as being a recommendation against, not a recommendation for clinical decision making.
And I'll just add to Dr. Messonnier, an ACIP recommendation for shared clinical decision making would add would be reflected on the adult immunization schedule, whereas if ACIP stays silent, it is not reflected on the immunization schedule, which alerts providers and provides them with the awareness to bring this to their patients to discuss.
And if I could add one more quick comment to that, it's also an issue of equity, right? Because it's the cost of the vaccine and who will have the access to the vaccine in the long run. Go ahead, Dr. Bernstein.
Along those lines, in the population between 27 and 45 years of age, how many do we know? How many of those have commercial insurance, and how many of those would be self-pay to get the vaccine?
Lori, any?
Well, I don't have those numbers, but I think you're getting at one of the important issues. Not everyone on the work group felt that clinical decision making would lead to equity, because it would be equity if you had insurance. Because if you didn't have insurance, and because there's not a lot of public funding for adult vaccination, it wouldn't necessarily increase equity. I think that's the point you're getting at.
Is there any comment from HRSA? Any comment from the liaison groups?
So I understand the rationale for ACIP making the shared decision recommendation, but I have to think about it that, if that is the case that we are thinking about, then ACIP would never make any recommendation that is not do not recommend, because the default recommendation would be a shared decision making. Which is important for ACIP to realize that if we make that decision, then every other vaccine, we will have to make that decision of shared decision making. But if we remember what is at stake and what we are considering here, unless somebody explain to me that is not what I heard, it says there is uncertain public health importance for expanding this. Essentially saying we have data to show that there is an uncertain public health importance to expand this. And based on that, shouldn't ACIP stand and say do not recommend in this case, as different from when we have a public health importance and we're now talking about payment and not. So that we're not defaulting into the idea that what ACIP does is only about rationing or paying and this, but there is a science to this, and the science says there is uncertain public health importance.
So a little bit about the uncertainty. I think one of the thoughts too is we automatically think about expanding this to all people, all women up to age 46, and I don't see that happening. What I do see happening is that women who are recently divorced, women who are getting married for the first time at 40 and actually have not been vaccinated, there are women out there at risk and could benefit greatly from the opportunity of getting immunized. And I don't want that opportunity only to be for the wealthy women. It needs to be for all women. And I think that's something to remember.
Dr. Atmar, please.
I just want to add, this vaccine is immunogenic and appears to be effective in this age group we're discussing here. And there are a lot of clinicians who go to the ACIP recommendations to look to see what should be done in managing their patients. And if we come with a do not recommend rather than the default shared decision making, which is already out there, that's going to have a significant impact, and particularly in a lot of clinicians for some patient groups that are going to have new risk factors and aren't protected but may well be susceptible and at risk. And so while I agree with you, shared decision making is the default based on any licensed drug, whether it's age group appropriate or outside a recommended or approved age group. The impact that this advisory group has on practice throughout the U.S. is significant.
Dr. Szilagyi and then Dr. Walters.
Yeah, thank you. I was going to make similar comments. I think within the work group, the vast majority, and I certainly think that a small number of men and women might benefit from this vaccine. I didn't hear anybody on the work talk about the large numbers, like the majority of the population benefiting. So that challenge is how to identify high-risk individuals. And to me, there are two groups of high-risk individuals: those who were high risk for HPV when they were younger and are continuing to be very high risk for new infections, or those who were not as high risk and now have a new sexual partner, or for behavioral reasons now are at high risk. And I think that latter group is easier to identify. I think shared decision making is done all the time in the adult world. It's sort of standard of care now in the adult world. And I personally am worried about equity issues. And to me, the important thing is to try to identify and then perhaps vaccinate the very small number of individuals who would benefit from the vaccine, and not vaccinate the vast majority of 27 to 45-year-old women and men. And guidance from the ACIP that could follow a recommendation of shared decision making, I think, could help that. I think we also need more research to figure out who are the very high-risk patients.
Dr. Walter. Yeah, I was going to echo that, Peter. I think really what's important if we do adopt a shared decision-making model is the guidance that will follow on for the individual provider in discussing issues of risk with their patients. So,
Dr. Fry.
I agree with the majority of what has been said here. I just wanted to also get back to the equity issue. It's more likely that an insurance company would pay for. I know this isn't our bottom line consideration, but it is a consideration. It's more likely that insurance companies would pay for a vaccination if it was recommended as if it was not.
Dr. Lee.
Thanks. Just to, I guess, this is such a helpful conversation for the next conversation we're about to have, so thank you. And I also wanted to, I think what I'm hearing is that with population level considerations, there's a yes or a no vote. And an example of a no would have been something like Rota Shield, where we said, at that point, no. But shared clinical decision making, to me, it sounds like is really about that individual and clinician decision, which I think is super helpful, recognizing that there is benefit to certain people, but that perfectly identifying every individual in a general recommendation is such a challenge. So this allows us the flexibility to be able to protect those that we think are interested in protection and maybe at higher risk for protection, but that could only be assessed in a sort of a conversational setting that can't be assessed easily by recommendation. That said, I wanted to actually just also specifically ask the work group if and I find this question about disparities really interesting. It's disparities for so many reasons. Part of it is access, but part of it could be many other reasons. And I'm wondering if we need to formally assess and evaluate the impact of any recommendation that we make on disparities. And I think that would be incredibly helpful, particularly as we move into the shared clinical decision-making world, that these decisions are no longer as straightforward as a yes or a no.
Dr. Warren.
Question came up earlier about insurance coverage among this age group, and at least according to the Census Bureau data from 2017, it's around 15% uninsured of this population. Now, I think Medicaid is probably considered insured, and to what degree Medicaid would cover this probably varies by state, but at least for the uninsured, it's around 15% in this age group, higher at the youngest end of the age group when young adults have, I guess, just aged off their parents' insurance potentially, and lower towards the end of the age group. But overall, it's around 15% or a little lower.
Dr. Szilagyi, although I don't have the number, and so the age at which young adults could be on parents' insurance is 26. So the issue of 27 to 45 that doesn't involve that. And among those who are insured, either private insurance or Medicaid, the majority is private insurance. I don't exactly know the exact number, but the number who are insured by private insurance is larger than the number who are insured by Medicaid. In Medicaid expansion states, it's more, but it's the minority, but a sizable minority in Medicaid.
Dr. Moore, please.
Thank you. One of the questions, and I really do appreciate the access issues that are being brought up, but one of the questions that I have, we have not seen anything presented around what we think the economic issues would be around shared clinical decision making. We've only ever heard estimates from a routine recommendation for this group. And while I agree with Peter and with Kip that among men and women in this age group, there are a small proportion who would benefit, we haven't seen what shared clinical decision making guidance would look like and what that implies in terms of the proportion of the population in this age group that would fall under those categories. And before I vote to recommend a shared clinical decision making based on guidance of that is not yet known, I would feel more comfortable having the information on what that shared clinical decision making would look like. Which people would we be recommending to be considered for vaccination, and what proportion of that population is that actually? And so that's why my preference would be to delay on that piece until a little bit later.
Dr. Hunter.
So I have, hello? Can you hear me? Yeah, okay. I have two general statements that are short, and I'll read them slowly. We should be careful to avoid making recommendations that inadvertently emphasize vaccinating adults more than children for certain infections, often because the benefit is more in the children and adolescents. And this includes HIV. And secondly, I'm concerned about the list of considerations for shared decision making that were listed. I think they're quite good for general reflection in an academic setting, but they may be very difficult to implement in clinical practice. Thank you.
Thank you, Dr. Freihoff.
Sandra Freihofer, American Medical Association, speaking as a practicing physician and as a member of the work group. As Dr. Markowitz said, this was a very difficult decision for this work group. There was a majority decision, but there was also a very strong minority decision. And I think Kelly brought up some important points. I've been very impressed by the deliberations I've heard here today. One of my great concerns as a practicing physician, as an internist who sees children and adults of all ages, is that there's only a certain amount of vaccine. We know that this vaccine works best in children. There's concern of mixed messaging, and having seen what has happened in the public arena in the past when a recommendation is made and the shared decision-making items are not so clearly defined, it may be expanded to people that don't necessarily need it, which is not a great use of resources. And this is not an inexpensive vaccine. It's a wonderful vaccine. It prevents cancer. It is, to me, just one of the most important things that this work group has ever come up with. In fact, at my very first ACIP meeting, the vote to give a HPV vaccination was voted on by ACIP. But I think this is a very tough decision, and I think the details of the shared clinical decision making need to be made very clear. This is not needed for every patient aged 27 to 45. Not needed.
Dr. Messier.
Yeah, thank you. We've talked recently at ACIP meetings about how the decisions we're asking you to make are harder than, say, a previous generation of decisions. And so I think this second issue falls in that category. We recognize that there is gaps in the information that you all have, and it makes it hard to make a decision. However, it isn't like we're going to have in a short term answers to the questions. And so, I just want to commit that whichever way you go, we'll make the appropriate research questions a priority. If it's the second that you don't recommend this right now, we'll work hard to see if we can firm up groups that are potentially benefiting or would potentially benefit from additional vaccination. and come back with that issue a couple years from now. If you go with the shared clinical decision making, it will clearly be a priority for us to figure out how that is implemented and what the implications of that are in terms of who's actually getting the vaccine. Is it exacerbating equity issues? Are there going to be supply issues? And so I know that there's some way you want to put this off, but it isn't like if we put it off in 6 months, we're going to have more data. And so we would like you to go ahead on the second question and come to some kind of consensus or conclusion with the understanding that, like anything, we're going to continue to research the issue and come back when we do have more data.
Yeah, I'd like to make just two comments, if I could, about Dr. Hunter and Dr. Freihofer's comments. In terms of the comment about the considerations that I put on the slides and whether or not they'd be helpful, I think the work group realized that those really weren't guidance, and we changed the term from guidance to considerations because it is true that it's very difficult to identify when you have a patient in front of you who might benefit and who might not. So we're terming those guidance considerations rather than guidance, and I agree that's something that needs to be worked on and refined more. And we do have plans to work and address some, to try to look at vaccine efficacy and effectiveness in special populations and do some modeling to see what additional, if we can identify people who would benefit and populations that might benefit. So I want to point that out. In terms of what Dr. Freihofer mentioned, I do want to confirm what she mentioned, that there was really a lot of discussion on the work group and the strong minority opinion and concerns about those who had concerns about a shared clinical decision making because of the issue of being difficult to identify people, and perhaps that would give license to some groups to be more actively promoting the vaccine. So there certainly was concern on the work group around some of those issues.
Dr. Middleman.
Amy Middleman, Society for Adolescent Health and Medicine. I really appreciate this conversation as well, and the shared clinical decision making. I think with that potential vote, I think it is important to have very clear guidance. I'm a little bit concerned about the use of gender identity as an identification of risk. I think gender identity is distinct from sexual behaviors, and so I think it's going to be important if we do work on shared clinical decision making that we create guidance that is as specific as possible, I think, about behaviors rather than about groupings of people. But I really appreciate the conversation, and I thank everyone.
Dr. Eckert from CAOG, please wait until we get the microphone to you. Oh, yes, okay. Yes.
Hi, I'm Dr. Linda Eckert from the American College of OBGYN, and I just wanted to assure the voting members, at least as far as ACOG's perspective, we've already had extensive internal discussions about how we would try to provide guidance for shared clinical decision-making, knowing that many women in our patient population could benefit from this vaccine, at the same time knowing that not everybody in this age group needs this vaccine. So I feel like this will be a very active area and that we will engage heavily in trying to assist our providers with guidance. Thank you.
I believe my question has been addressed, and that was on guidance provided with the recommendation.
Dr. Rockwell from AAFP.
Hi, thank you. Pamela Rockwell, American Academy of Family Physicians. I feel like we're almost giving this too much discussion and weight here about clinical and shared decision-making because I'm in clinical practice. I see kids, I see adults. I've been doing this for over 25 years. It is not difficult to recognize who might benefit from HPV vaccination with your newly divorced woman who is coming in, or your patient who is 28 years old and never had sex and is now getting married. So I think that we don't need to get that explicit in these recommendations, number one. And number two, I think that we are giving HPV once again more attention than it actually needs compared to other vaccination recommendations. When we look at the recommendations for boys, say, or young men, for the shared clinical decision making, we didn't have this kind of discussion for those men ages 21 to 27. So that is it. I just want to say shout out to family physicians and all primary care physicians that we can make the decisions without as much guidance.
Dr. Szilagyi, thank you.
Yeah, just these are all wonderful points, and I very much appreciate people's thoughts on this. And just to expand a little bit on what Dr. Middleman was saying, I do think it's very different in the adult world to identify, it's much easier in the adult world to identify behaviors. And I hear what you're saying in terms of maybe not being too explicit about that, but it's difficult in the pediatric world to identify, it's much more difficult to identify either current behaviors or behaviors in the next year or two. That's really difficult to do in the pediatric world, but in the adult world, I think that discussion in the shared decision making is a much easier thing. Adults, internists and family physicians do this all the time, and I do think that this is about behaviors and not identifying demographic characteristics.
Are there any other? Oh, Dr. Ejek.
So I mean, I think HPV vaccine does require the attention that it's getting. It is really something that is important. If you, as I have witnessed family members who have died from this cancer, it is a very important vaccine. So the idea to support it in terms of making sure that everybody get it, if it was to be mandated before 26, I would have said let's mandate it before 26. The whole idea is I want people to get the HPV vaccine. I want them to get it when it's most efficient. I want them to get it when it's most cost effective. I want them to get it when it makes more public health importance. So the idea here is not about limiting people to getting HPV vaccine. It's actually increasing people getting HPV vaccine by focusing on the target group that we get the best bang for our money. The group that we have shown that is most effective, the group that we show that is of more public health importance, the group that we have shown that if we focus and target on them, that will achieve the greater good for everybody. So I think getting HPV vaccine is important. I think we should push for it. What I'm challenging, though, is that the shared decision-making is a different thing from saying a target group. So the idea of, I hear the question saying a woman who divorced, who said that a woman who divorced did not get it at 16? So it's not really a focus group. We're talking about people who have not received it. So whether they divorced, whether they have new, the idea is that if they already received it, it didn't matter if they divorced, it didn't matter if they have new sexual partner, if they already received it. So the idea is to get them to receive it. The challenge I have here is that if ACIP makes that decision and it becomes the ground to do it, I don't see any other time ACIP could say no to a vaccine. Because once FDA approves it, FDA have said this vaccine is safe. That is not the role of the ACIP, it's the role of the FDA. So once FDA approves it, what goes in my mind as a clinician, and I practice, and I'm an infectious disease doctor, is that you now have a shared decision background. So when FDA approves it, when then can you say no? I thought that when ACIP can say no is when there are other considerations. And this other consideration here includes use of resources. Should we use the resources to target increasing immunization at the 10 to 26 years? Or should we use those resources to focus on a very small group where there have been questionable public health importance? So it's not about HPV vaccine not being given. I want to give it. So I just wanted to make sure that's
I just want to say, I think that the point you're making is exactly why no one on the work group favored a routine catch-up through age 45 years, and is also one of the reasons, of course, why some work group members had concerns about resource use for even shared clinical decision-making. But it certainly entered into the decision about not extending the routine catch-up through age 45.
Unless there are any other comments, then what we need to do now is have a motion for each of these two, and then a second for each of these two recommendations, and then we will vote in the afternoon after public comment.
Peter, Dr. Szilagyi.
I'll make a motion. This is for the harmonization. Okay, so I motion that we change the recommendation to ACIP also recommends catch-up vaccination for persons through age 26 years who are not adequately vaccinated.
Do I have a second?
Second.
I'll second the motion.
Is there any further discussion? Okay. Okay. So we have a motion and a seconded. It's carried to vote in the afternoon. Our next, I need another motion now for the second recommendation. Dr. Fry, please.
Is it on? Hello? Okay, I make a motion that we approve the, can you hear me? I make a motion that we approve that ACIP recommends HPV vaccination based on shared clinical decision-making for individuals ages 27 through 45 years who are not adequately vaccinated. HPV vaccines are not licensed for use in adults older than age 45 years. Thank you.
May I have a second, please?
Second. Can you
Dr. Lee, thank you. Any other further discussion? Dr. Hunter.
May I make a motion that we instead recommend that HPV vaccination for adults older than age 26 is not recommended?
No, we have to vote on the first motion, and then if necessary, we would take up your motion. Any other comment?
I'm not sure that makes sense logically, and I would object to that because if you reject I think the order that would make more sense would to start with the not recommending, and if that gets rejected, then go to shared decision making.
So, but go ahead, please.
Just that the motion that was put on the table was already that the recommendation for shared clinical decision making. So if that motion does not pass, then another motion related to the same issue can be put on the table.
Right. We need to vote on the motions in order of their proposition, if that's the correct way of saying it. Proposal. Any other comments? Okay.
I just want to remind everyone that we are making motions for votes, and then we are staying the actual voting until the afternoon session after our period of public comment, which will occur after lunch. I also want to let everyone know that we are running a few minutes late, which is fine. It is 10:30. I'd like to start immediately at 10:45.
So break until 10:45.